let's get started. You guys know how these work. I'm actually going to keep the slideshow open a little bit so I can still see you and your comments come through. This is an important topic, in my opinion, melatonin. One of the easiest things to add to a cancer routine, and so few doctors do it. So I wanted to go through, why do we do that? Because there's a lot of confusion at the beginning. Hey, I don't have trouble sleeping, not sure about this. Why am I adding melatonin? So I wanted to go through the data on that and introduce you guys to some of the background of it and answer any questions, kind of do a deep dive on why do we add melatonin to our protocols. So the roadmap tonight, we're going to start with what is melatonin, how is it made in the body, what are its functions, what are some of the common misconceptions on melatonin, and what's the role in cancer treatment, and is there any data on that? So one of the things I don't do a lot of in our individual appointments is go through data. I'm not a study person. I believe the journals are all corrupted and that they're all biased against especially what we're doing. So I don't put a lot of faith in that, but there actually is data for everything that we do and incorporate into our protocols. So we have that, and I always want to share that with you. So when you go back to your standard of care team, you can say, here's some data on this, and share it back with them and maybe get that dialogue going a little bit if you feel inclined. Never any pressure to do that, of course. So what is melatonin for my chemistry junkies? Here is what that looks like. This was discovered in 1958 and is produced by the pineal gland. So if you remember, the pineal gland sits between the eyes. This is why we don't put fluoride in our water, because it fluoridates the pineal gland and causes disruption there. That is where it comes from. It starts with tryptophan and then undergoes these different processes. Some of you might have seen 5-HTP as a supplement, serotonin you recognized. So we get down, it goes through this pathway and gets hung up and then becomes melatonin. So there's actually a lot of medications that interfere with melatonin production and can really disrupt people's sleep. So a lot of times anything you'll see, especially in the psychiatry world, it comes, if you see somebody on a psych med plus trazodone, that's usually because it causes a melatonin deficiency. The patients can't sleep, and then that gets added. So a red flag on there. So what does melatonin do in the body? Obviously, we're using it for a specific reason, but what's the overall purpose? And I think if you ask any of us, your knee-jerk reaction to what is melatonin, it's a sleep aid. It's actually not a sleep aid, even though that is 99.9% what it is marketed for. So secretion of melatonin actually goes up in the darkness and decreases during exposure to light. So what it does is helps regulate the circadian rhythms. So for some of you, we've talked about how to regulate your sleep-wake cycles or how to get into that sleep routine if you're not sleeping well. That's actually really important to recovery from a malignant process. If any of you we've ever told to go outside in the morning and don't wear sunglasses and let your eyes get the first morning sun, that activates that pineal gland to set your circadian rhythm. So there's actually a really good reason that we ask you to do that. That helps foster that melatonin production. This is why we look at blue lights in the evenings and say, shut your lights off, go to those blue blocker glasses, get the screens away from you, and get your sleep hygiene in order. And that's one of those processes. So it works in regulation of mood, learning and memory, immune activity, which is really important to what we're talking about. Some of you have said when you take melatonin, you have vivid dreams. That would be understandable. It also has a role in fertility and reproduction. So a lot of the things that come from the pineal gland and the hypothalamic axis, the pituitary gland, are going to be tied into fertility and reproduction. So no shocker that this may affect that as well. But what we're really going to focus on today is the fact that melatonin is a very effective antioxidant. It's actually a little bit stronger than vitamin C and vitamin E in the body at those antioxidant doses. So that's really the reason we are going to incorporate it in what we're doing. So how does melatonin work? So you can see melatonin here is both a direct antioxidant and an indirect antioxidant. So directly it sorry, this is a little blurry, but it scavenges free radicals directly, but indirectly, it also stimulates things like sodium dioxide dismutase, and things like glutathione. So it's going to indirectly boost those, which is going to scavenge your reactive oxygen species. It's going to reduce and it's going to increase your antioxidant buffering capacity. So as your body is making free radicals, your body is making these oxidative reactive species, you have a sponge to soak them up so they're not doing downstream damage. They also think that there may be a role epigenetically. So we think of our genetics as fixed. We think of that as the Rosetta Stone. It's etched in stone. It's not. Our genetics are light switches. We flip them on and off. So everything we do can change how our genes are expressed. And the example I'd used before that might be familiar to some of you, they took prostate cancer patients and they gave them 1 cup of broccoli a day. That changed 80 genes. 1 cup of broccoli a day for 1 month changed 80 genes, the expression of 80 genes. So it doesn't change the DNA, it changes how the DNA is expressed. And melatonin can do the same thing. So if we look at things here, inflammation, obviously this is the hot spot of what we're talking about. We have people who have uncontrolled metabolic issues. We're talking about metabolic health, neurodegenerative. So we really should be using melatonin much broader in our patient population. But we've decided to focus on the patients dealing with the terrain approach is where we're going to focus this and then figure out who would most likely benefit from it from a cost analysis. So if it does all of those things, shouldn't we be using it clinically more often? And this is a paper that says, yes, basically we should. And again, in the areas of longevity, in oxidative stress, in chronic disease management, and always cancer is tucked into that. But how does this specifically tie to cancer care? How many of you knew that night shift workers actually have an increased risk of cancer? Raise your hands if you knew that there's an increased risk of cancer. Let's see. Just one of you? Okay. Yeah, there's a real tie there. And this hit quite close to home because I don't know if I'm high risk for breast cancer myself, family history, and was a night shift person. I worked in the ICU overnight for a long time. So this is something that disproportionately affects those night shift workers because it suppresses melatonin when your sleep cycle is disrupted. If melatonin deprivation and sleep dysregulation causes cancer, maybe there's a chance that we can use it to treat it. So I want to break into the top 10 misconceptions about melatonin. I think I've heard every one of these from different patients. So we'll start. Melatonin is only for sleep. As I've established, it's actually a really good antioxidant. So we just need to shift how we think about that. And what's really frustrating, I've had a number of you go to your doctors or even go with a friend to a doctor, and the doctor say, oh my gosh, you need to stop taking that 150 or 300 milligrams. And I have to say, I'm a little bit guilty of that myself, because if you remember back at LCCC, they had their melatonin protocols and they were advocating for 20 milligrams a day of melatonin. I thought that was too much. Again, I want to give everybody the opportunity. Knowledge replaces fear. And the more we learn about these things, the more we shift our thinking. So most of you know that now we're doing 150 to 300 milligrams per day as tolerated in our patients. So it is not a sleep aid. And again, immune regulation, circadian rhythm, tumor biology directly. We're going to get into that a little bit. So it is not just for sleep. It is unsafe to take more than 3 to 5 milligrams. So one of my favorite researchers, I believe his name is Dr. Reiter, Reiter. I was just watching his video prepping for tonight. He's 88. He gave a talk to us last February and said, I've been taking this for 30 years at 180 milligrams a day. He's one of the main researchers who's published on this. So the research, especially in oncology, is hundreds of milligrams a day. So do not be concerned about that it is unsafe to take these big doses. We know that it is. So misconception number 4. More melatonin makes you groggy the next day. So some of you have incorporated this into your plan and you know that right away you can have some fatigue. I've taken it while I'm seeing patients. Felt like I got hit by a shrink dart. But when you take it every day and your body gets used to it, really that daytime sleepiness goes away. As we troubleshoot this for people, if you start taking it and you're super tired, I just have people move it to bedtime. And as your body gets used to it, we'll slide it back up earlier during the day, and we'll explain why we do the daytime dosing. It only works if your body makes it. Guess what? This is another bioidentical hormone. Melatonin, it has a chemical structure. It doesn't matter if you make it or if it comes from a bottle. It's the same. It's your body receives it the same and it works the same. It's produced in every mitochondria. So no surprise that if you have a mitochondrial problem or a metabolic problem, you're not making melatonin effectively. And again, this is going to influence that mitochondrial pool, because if we can get in there and clean out the cytoplasm of the cells with this, it's going to have a positive loop effect. Doesn't matter in cancer. It doesn't work. Actually, I'm going to present some data here. You're going to recognize some of these pathways that it works in. And the integrative approach in cancer is very different than the standard of care. You all know that. And what I'm finding is the standard of care oncologists are moving toward genetically testing and saying, you have this mutation, so we're going to give you this mutation blocker to block this pathway. Doesn't work. You didn't get cancer because of one mutation. It is a myriad of changes that accumulated to cause disruption in normal cell biology. So it has documented effects on apoptosis, telling cancer cells to go bye-bye, like you're done, game over. It blocks angiogenesis. So what happens when tumors grow, they outgrow their oxygen supply. So they have to create new blood vessels. This blocks angiogenesis, so it can't do that. Tumor metabolism. So these are cells that have to take up nutrients. Melatonin can block the nutrient uptake in the cells. And immune modulation. So again, this is not only a metabolic problem, it's also an immune problem, because your immune system has been killing cancer cells since the day you were born. And it's still doing that. It just gets out of balance. So we need to get that immune system balanced back out so that your body can function normally and handle the tumor. This is one of my favorites, and this is just plain straight wrong. Melatonin interferes with chemotherapy or radiation. So it actually, across studies, shows that it enhances the efficacy and it reduces the side effect, reduces the toxicity of both chemotherapy and radiation. So especially if you are doing these treatments, you need to be on good doses of melatonin to protect yourself. And some of you have received our radiation protocol. So before you're going to have scans, we're actually going to do high doses of melatonin to protect you from the radiation in those specific scans, not to mention just radiation therapy in general. So it did not interfere in a negative way. It augments what you're going to do with that. And I consider it a necessary part of treatment to have better overall outcomes. Natural melatonin from the store is too weak to matter. Again, if you go to where you buy toilet paper to buy your supplements, you're probably going to have a crappy outcome. You're going to hear me say that all the time. So many people come into my office and say, I can't sleep. I've already tried melatonin. And I ask where they got it. And I say, try pharmaceutical grade and then come back and talk to me. And most of the time, the pharmaceutical grade works better. So you need high quality supplements. You need to take them at proper doses. You're going to have a different effect. So important to remember, quality matters. Melatonin is only useful for hormone-related cancers. Actually, there's a lot of evidence that in most solid tumors, there is efficacy. And there's actually a paper I pulled that looks at it for leukemia and lymphoma as well. So across the board, we're generally considering melatonin for most of our treatment types. It has a special benefit in people with hormone-related cancer, prostate, breast, uterine, ovarian, because of one of its properties. I'm already sleeping. I don't need melatonin. Again, we're not using it for sleep. It does regulate your circadian rhythm, but we're using it for that antioxidant, that cellular protection, that cleaning up the damage inside the cells. So there's a purpose beyond just you sleeping. And then again, they're just trying to sell you supplements. It's just another bottle, another thing you have to swallow. No research, right? There's no research. That's just orange juice in your IVs. That's craziness. That's quackery. I've been called every name you want to say. Melatonin is actually one of the most studied natural molecules in cancer care. So it is a shame that standard of care doctors do not 100% include this because the data is so strong for its use. It's almost malpractice that they don't. Decades and decades of data for this. So it's shocking to me that it's not included. But think about it. No one is going to get rich selling you melatonin. Nobody's going to get rich selling you mistletoe. Nobody's going to get rich doing IV vitamin C infusions. It's just not going to happen. There's no payoff that is worth the effort to educate standard of care to do this. Think about their treatments. We're talking $10, $20, $40,000 a dose once or twice a month. That's some big money. This is what, $50 a month? Nobody's getting a big payoff. So speaking of research, there actually is some. So I highlighted a few of these, but we're going to look through these a little bit. And some of these are bench research, and there's a few that look at outcomes as well. There's a randomized controlled trial I'm going to pull out after this. So that pro-apoptotic signals cells to die and cell cycle arrest. This is what chemotherapy does. We see this also in CHOP protocol. Does that sound familiar with any of you for lymphomas? So positive in that. Anti-angiogenic VEGF. Some of you have your genetics tested for VEGF. This is anti-angiogenic. It reduces that blood vessel accumulation. Anti-inflammatory. Most antioxidants have an anti-inflammatory component. Immune modulation. Again, we want to balance out that Th1 to Th2, and we want to increase the NK cell, the natural killer cells. So when we're looking at your neutrophil to lymphocyte ratios every month, this is one of the things that can help us balance that out. Endocrine and estrogen receptor signaling in breast cancer. So it downregulates the estrogen receptor alpha, which is the problem. There's also an estrogen receptor beta that's not a problem. That's what testosterone hits. So there's a difference in there. Inhibits the aromatase. So how many of you are on aromatase inhibitors? We're talking inastrozole, letrozole. We're talking quashing hormones. This actually has some viability. So imagine we don't quash hormones. Instead, we do some melatonin, we do some DIM to make sure those hormones can come in and do what they're supposed to do. They don't go down a bad pathway, and then we make sure they get detoxified out of the body. You're going to feel so much better than just quashing what your body needs to function in the first place. Metastasis. So reducing metastasis, reducing that ability for those tumors to go outside. Managing oxidative stress, looking at the circadian and the chronotherapeutics, so the light effects in cancer. We're starting to see a movement toward ultrasound therapy, histotripsy, frequency, vibration. That's part of the spectrum, the sound and light spectrum. We're starting to see that. And then again, DNA oncogenic signaling. We're talking epigenetics here, changing those. So there is a lot of data on the use of melatonin. So speaking of, this is a review of randomized controlled trials and a meta-analysis. So I'm just going to review this. So this is looking at a systematic review of randomized controlled trials. So your meta-analysis is above a randomized controlled trial. So randomized controlled trials take you and say, you get this and you get this, and we only give you one variable and we compare the difference. The meta-analysis take all of those studies and look at the overall. So it more reflects real life than any of these randomized controlled trials, because I don't know about you, every single person on this call has multiple thousands of variables, from lifestyle to inflammatory status to nutrition to where they live to how you detoxify. So how you can ever randomize that totally, I don't know. But think about it. Effects were consistent across melatonin dose and type of cancer. So melatonin reduced the risk of death at 1 year, 60 to 70%. 60 to 70%. So no severe adverse effects were noticed. And yeah, that's pretty overwhelming to me that a supplement, it has better efficacy than a lot of the FDA approved treatments that are coming out now. And it's a relative risk of 0.66. So it's actually a risk, it's a death reduction of about 30%. I misspoke a minute ago. But relative risk 0.6 to 0.7. So 30 to 35% lower risk of death at 1 year. It also radiosensitizes in cancer patients. So anyone undergoing radiation therapy, I really want them on melatonin to go in and actually trigger that oxygen reactive species in the tumor cells. Here's just some of those 17. Some of those 17 mechanisms against cancer, you can screenshot this. IGF-1, this is insulin-like growth factor 1, EGFR, what else? P53, this is a tumor suppressor gene. It upregulates that. It upregulates VEGF. It reduces MMP9. This is an inflammatory gene. So we see a lot of different targets for flipping those light switches on and off in a good direction as the cells become, or these are the changes, that we see as tumors grow. This is what it gets targeted. I'm just going to say this a little bit different way. So it induces apoptosis. So signals cells to die, blocks the blood vessel formation, blocks metastasis so that those tumor cells can't go out and stick into other places. It's the basis for why we do things like aspirin or dipyridamol, Agrinox. It suppresses those adhesion molecules that make those cells sticky. Anti-proliferative effects, so it slows down the tumor growth, regulates the immune function. So we all want more NK cells, those natural killer cells. T cells, these are your lymphocytes, right? Cytokine balance. So we don't want to be in a super inflammatory state. We want to be in a balanced inflammatory state. So you guys know one of the things that we track is CRP and acetate. You also can track IL-6, IL-8, things like that. Improves the circadian rhythm. Of course, that's always going to be on here. And for people who have regular sleep, less downstream stress, that does have a positive feed-forward loop on patients as we're trying to get everything lined up in that terrain. Antioxidant activity. So this is one of the most powerful things it does. It scavenges those free radicals. It acts like a sponge to soak those up. Some of you I've been talking to about pomegranate juice does kind of the same thing. We want to be careful with that approach in cytotoxic chemotherapy, but overall it's positive. Protects normal tissue from chemo and radiation, while it's sparing healthy cells while putting a target on the cells that we want to go away. Mitochondrial support. Again, melatonin is made by the mitochondria, but a feedback loop, it increases ATP, which increases energy, which is a net positive. If we think about this as a metabolic process, more energy production in the good cells is always going to be better. Epigenetics, we've talked about that. Flipping the light switches in a good pattern. So endocrine modulation. So again, that aromatase inhibitor balances the estrogen testosterone. Some of you with hormone positive cancers, we're starting to incorporate testosterone therapy. We know how that interacts with the different estrogen receptor sites. And really the data for a lot of hormones, we're hearing the FDA come out and say, oops, sorry, we lied to you. It's not quite what we told you. We robbed you of hormone therapy. We're using that strategically right now in certain patients. Inhibits telomerase. So telomerase is the one that chops off the DNA, that healthy ending of the DNA that protects it. Telomerase chops that off. So anything that preserves our telomeres is going to be positive for longevity. Anti-inflammatory, we've talked about a few times now. Enhances P53. So P53 is a tumor suppressor gene. That's one of those genes that the spike protein shut off. We can turn it back on with the melatonin. Modulates the oncostatic signaling pathways. So some of you, again, the Wnt pathway, MAPK gets tested for. You're starting to see these come back on your Guardian 360 reports. I'm not super slick with them yet, but we have the pathways, and you just need to know that some of the things we do on the integrative side are hitting those pathways, even though we don't explicitly explain that and think of it that way. So the last two, inhibits aerobic glycolysis. So you're going to reduce the glucose using properties of the cell. So that Warburg effect. So in normal cells, you either get to pick oxygen and fats to burn for energy, or you get to pick sugar. Cancer cells have figured out how to do both at the same time. That's the Warburg effect. Otto Warburg got a Nobel Prize in the 1950s for figuring that out. We're going to shut that process down. Same thing like the ketogenic diet does. Same thing that we try to do using other mechanisms. It also hits those cancer stem cells. So we talk about this a lot. Cancer stem cells, high dose vitamin C, melatonin. We're going after those. Those chemotherapeutic agents miss those because they're only going to rapidly dividing cells. These guys are just hanging out, waiting for the decks to clear, and then they pop their ugly head. So that melatonin goes after those as well. So how do we use it and why do we use it this way? If you look at the natural melatonin production, so this is nighttime. So this is 2 a.m. So we're going to start at noon. At noon, we're going to see that spiking up around 8 o'clock, 10 o'clock. Your melatonin spikes until about 4 a.m. and then it drops off. We want to boost it during the day when you're naturally low. So this is why we dose it at 10 a.m. and 2 p.m. We dose it at the lowest times to compensate physiologically for when you're naturally lower. So 150 milligrams, 10 a.m. and 2 p.m. Not everybody can tolerate that dose. So we now have a 20 milligram we can start with. There's a 60 milligram that's available. We can work our way up on that. We don't have to hit it all at once. And I don't want my patients sleeping all day to treat what we're dealing with. We can always shift it to bedtime. We can do it once a day with the 150 and we can move it earlier as the patients get used to it. No problem. We also use it in our radiation protocol. So 300 milligrams 2 hours prior to imaging to reduce the radiation exposure. And here's a picture of this for any of my physics people. So you're exposed to ionizing radiation. You have antioxidant destruction and both melatonin calm that down and so does vitamin D. So this is very protective with x-rays. I am going to stop sharing my screen now and open it up. I went through that fairly quickly, but I'm happy to take questions and answer those. A lot of you have been on this protocol for a year or longer. I think the majority of patients have had a good outcome or have a good experience with the melatonin. They've been able to incorporate it without too many issues. So I did see a hand go up. So let me get a question in the chat. Okay, Robin, so you got sorted out. Okay, you're in, so we're good. All right. Any questions about melatonin to truly anybody who's on here? Because I see some people who are not in our terrain program. Even if you're not a terrain patient, that's what we call our cancer patients, because who wants to hear the C word all the time? We're really focused on improving your terrain so that cancer can't live there. So we focus on the positive. So if any of you are dealing with this, if any of you just want to be healthier, melatonin is probably a good thing to add at some level to your protocol. So I'm a fan of that. It doesn't have to be every day if you're healthy. If you're in a position where you could benefit from higher doses of this, obviously we want to get it going twice a day for you. And get the destination is that higher dose, but we just don't have to start there. All right. I'll give just a couple of minutes for questions. I appreciate you all being with us tonight. Again, this is the makeup. We are really getting in the groove of every Monday at 6 o'clock. We have something to offer you. Our terrain patients, I hope you're coming to the 9 a.m. on Mondays. That would be a great thing for you to come to. Our nurses are really doing a deep dive on the terrain aspects, like how to detoxify your products and your home environment and EMF and how to deal with inflammation. So that's going to be a great thing to work through. Oh, there are some questions. So are there any patients where the melatonin will be contraindicated? There are a couple of interactions that it has. Literally, it's 1 or 2 cancers. So it's not going to apply to about 99.9% of patients. Terry, I've taken very low dose melatonin years ago, but had nightmares. Any way to get around this? So I would just try the higher doses and I would see how you do, because again, everyone reacts a little bit differently to this. And when you get a really high quality melatonin, if it doesn't work for you, let us know and we can figure something out. But I would definitely try it again. I would try a pharmaceutical grade, pure products, and go that way. Yeah, John's working on the twice a day. And again, there's ideal and I'm a realist. So we all have a life to live. We have realities to deal with every day. So the ideal is 10 and 2. If you're trying to work in a job and that's not feasible for you, maybe you can get it in at noon and after work. So I will get it in versus the very, very best. but the optimum is 10 and 2 because of that curve that I showed you. John, I might just have to come to Mexico and bring you your supplement. I feel like that's a really good compromise. That's going to solve your problem. It's going to solve my problem. So let me know where you are and we will work out a drug drops in Mexico. You heard it here first. Betty, great. I had no problems on the 300. Yes, and we have good news for you. So that is great. Let's see. What else did Betty do? If Betty wants to speak, I'm happy to give her the microphone, but I'm going to preserve confidentiality from up here. For non-cancer patients, is 150 twice a day still a good dose? It might actually be a little too high. Again, this is an antioxidant, so it's going to be pretty safe. You may not have to do that much. So it just comes down to an expense and effort issue if you're not doing a terrain focus. For anyone who's in the middle, so for those people who are dealing with working up, possible cancer, my gentlemen who have that PSA elevation where things are looking a little funny on the MRI, but they don't with the biopsy, I'm going to lean to the side of more aggressive. For me, I should probably take 60 to 150 milligrams a day just as a nice routine. It is that powerful. So it may be a good thing to add into what we're doing. Great questions tonight. Great turnout. Again, this was makeup from the 8th. So I'm sorry for those of you who came that night and I missed it. It was just a total goof, but we're getting over that by every Monday night. So the first Monday is for our concierge patients. So all of you, I believe, are included. The second week is the terrain focused, a specific topic to the terrain. One of the upcoming is going to be mistletoe. A lot of you have asked me for data on mistletoe. Again, I just can't get into that at the appointments. There's so much we have to cover. So this is really augments what we talk about in the appointments to do a deep dive on each topic. What's the data behind IV vitamin C? So that's the kind of thing we'll be talking about here. And then hopefully I see Sherry and hopefully the nurses also, we can start integrating some of the terrain specific things in here too. But I wanted to hit the things that affected a lot of people across the board. You mentioned a rise in glutathione. Some of glutathione is good for cancer patients. Oh, that is a video I've heard last night from the amazing Paul Anderson. So I just shared that with my team. That'd be a great topic as well. And the answer is, I don't know. So we know the glutathione is the master antioxidant. So any cancer patient undergoing cytotoxic chemotherapy. So this is not immunotherapy. Is not hormone therapy. So cytotoxic chemotherapy, we avoid antioxidants. So that's popping them to oxidative stress. So that's creating those free radicals. So those fragile cancer cells go bye-bye. That's the whole point of that. So we don't want to give sponges that soak up all those oxidants, those reactive oxidative species that we just created with the treatment. We don't want to soak those all up before they've had a chance to work. So we're generally going to avoid glutathione around like the day before, during, and after any of that cytotoxic chemotherapy. For other patients who are not on that, it might be a positive thing to add. So again, standard of care says if you give an antioxidant, you're protecting the cancer. So we avoid glutathione, selenium, vitamin C at low dose, vitamin E around that therapy. And we just withhold it from those patients in general. So anybody who's getting high dose IV vitamin C, that is an oxidative therapy. So we do not give glutathione at the end of those infusions because we are creating those reactive oxidative species with our infusions and we don't want to mop it up. We want that to get in there and work. So hopefully that answers your question, which is I don't exactly know, but I know it's circumstances we need to avoid it. And there are circumstances where it is safe and it's more of an individual thing. Great questions. Where to buy the high quality melatonin? There's literally only one company I know of in the country that makes it, and we carry it from them. It's Select to Balance. So we carry the 20 milligram and the 150 milligram right now. We also have the low dose 1 milligram for people. We may actually do away with that at some point, but we have a few people who take that. So 1 milligram, we're focused on the 20 milligram and the 150 milligram. Very good. Feel free to email back to us with suggestions of topics. I always like to know about what you want to know more about. We're introducing something new called a quarterly focus. So every 3 months, we're going to have a general topic that we're just going to basically have all of our information revolve around. So the quarterly focus, you're the first ones to hear it. The quarterly focus for October, November, December is going to be hormones. So we're going to talk about hormone replacement in men, in women. We're going to talk about thyroids. We're going to talk about adrenals. We're going to hit a lot of hot topics. We're going to hit a lot of things in the news about those topics. So that is our fall topic or Q4 topic, our hormones. Very good. And thanks everybody for being here. We appreciate it always. Have a great night.